Awesome, thank you. So good morning, everyone, and thanks for having me to speak about this topic. And this morning, I'm going to continue, my quest to try to find a topic that both andrologists and oncologists and really anyone doing general urology may actually find useful and interesting. And as Dr. Gleave said, this is really not an uncommon scenario that we may encounter in not just an andrology clinic, but in any general clinic or oncology clinic, which is the issue of testosterone supplementation in patients either with prostate cancer or with a history of prostate cancer. And so to attempt to address this question, I'm going to walk through a number of different sort of clinical scenarios that you may encounter, and we'll talk about how you might manage each of these based on the available data today. And this is a controversial topic. So if there's anyone who has any comments or strong feelings about any of the evidence or ideas that I present, just please feel free to interrupt me and we can discuss these points as they come up. So to understand why we even have to have this discussion, we have to travel back a little ways to the 1960s with Dr. Huggins, who was one of the first researchers who identified this role of hormones in prostate cancers, and he actually won a Nobel Prize for this. And one of the papers that's had the greatest impact on our field in this area was one that he published showing that the tumor marker prostatic acid phosphatase increased in one of 3 patients that he published on. All of these men had metastatic prostate cancer, and he had injected all of them with testosterone. And so this set the stage for essentially a decades-long held belief that testosterone is really the fuel for prostate cancer, and essentially initially must be avoided entirely in patients with prostate cancer. And so this concept that any testosterone would fuel prostate cancer growth has come under scrutiny in the last couple of decades. And really what we're beginning to understand is that perhaps this model is not as simple as testosterone being the gas pedal for prostate cancer, and that there's likely more nuance to this. And so researchers have begun asking this question, trying to see if testosterone levels actually correlate with increased risks of prostate cancer, or if someone does have prostate cancer, worse disease. And so before we delve into testosterone replacement therapy, let's sort of first look at some of the natural variation of testosterone seen in the general public and see if that affects prostate cancer risk. And so there's a study, the endogenous sex hormones and prostate, that was done by the endogenous sex hormones and prostate cancer group, which published a meta-analysis of about 18 studies that had all been completed by 2008. And this comprised several thousand men, both with and without prostate cancer. And so they assessed across several different hormones, such as things like free and total testosterone, DHT, estradiol, and they were really not able to find any association with testosterone levels and the risk of developing prostate cancer. And even within the study, there was really no statistical evidence of any heterogeneity between these studies. They did attempt to control for potential confounders, and really this made little difference from their point in terms of their risk estimates. Even when they're trying to compare between local and advanced prostate cancer, which is what we see here in this forest plot, they really saw no difference across any of the different hormones that they looked at, like testosterone, free testosterone, or DHT. There's been other studies that have tried to attempt to answer this question. There's actually a sub-analysis of the placebo arm of REDUCE that was published a few years after the original REDUCE trial was done, that shows that in their placebo arm, men with normal or even elevated levels of testosterone, so above the normal range, really had no association with an increased risk or rates of aggressiveness of prostate cancer. So now that maybe we've addressed that sort of the natural variation that arises in the human population of testosterone is not associated with an increased risk of prostate cancer, what about hypogonadal men, so men who have a low testosterone value? This question actually has far less research into it. One of the larger studies looked at a group of a few hundred men and found that those with the lower testosterone values, below roughly what our cutoff in Canada would be for a diagnosis of being hypogonadal, actually had an increased risk of prostate cancer as compared to those who had a normal or higher value of total testosterone. And the observations and studies like these left some issues with this original model from the 1960s of testosterone potentially being sort of the pure driver of prostate cancer. And so the saturation model was generated to try to reconcile this disparity between observing, the effectiveness of things like androgen deprivation therapy in treating advanced prostate cancer, and this simultaneous lack of an effect of increasing testosterone levels beyond, this castrate or near castrate level upon prostate cancers. And so put simply, the saturation model posits that androgen receptors on prostate cells are maybe only responsive to fluctuations in testosterone within a significantly low range of this androgen, likely close to that of at castration levels. But beyond a certain point, the androgen receptor, which is they term the androgen receptor saturation point, any additional rise in serum testosterone levels maybe doesn't confer any added risk for malignant proliferation. And Dr. Morgenthaler out of Boston was the one who originally sort of described this. Based on his original description, this range sits somewhere between a testosterone value of 2 to 4 nanomoles per liter, above which testosterone is proposed to really have little effect on tumor growth. Now, this saturation model is not maybe yet considered entirely gospel within our field, but it does raise an interesting description of a potentially more intricate relationship that might exist between testosterone and prostate cancer. What remains, unclear, however, is why the men in the previous studies with a lower concentration of testosterone, so these hypogonadal men, are suggested to have higher rates of prostate cancer. Perhaps this is ultimately a question of receptor and ligand, and so far we really focused a lot of research on the ligand, testosterone, when the androgen receptor is likely playing a role with potentially different receptor dynamics in patients and their specific cancer. And so why should oncologists or the general urologists even care about testosterone supplementation and trying to supplement men who have low testosterone? Well, this is a pretty prevalent issue. Most studies trying to assess testosterone values will agree that total testosterone levels will decrease as we age. Most of these studies have been hampered a little bit by varied study designs and methods of analyzing testosterone. There's also no real clear inflection point similar to menopause found in females that can be easily identified in males. Studies that have tried to look at the epidemiology of hypogonadism are poor, to be honest, with really no great screening trial. Most estimates suggest somewhere between sort of 5 to 15% of men over the age of 60 likely meet the criteria of being hypogonadal. One of the largest studies, which is this European male aging study, found that a rate of about 5% in men over the age of 70. Whatever the exact number, what's important is that any center dealing with, even a moderate volume of prostate cancer patients is certainly going to have men who also have hypogonadism coming into the clinic. So now that we know that hypogonadism is a common problem, we also know prostate cancer is a common problem. Let's walk through a clinical case, and then we're going to discuss these different scenarios that can come up for patients as they deal with being both hypogonadal and having prostate cancer. So some of you may recognize my patient from my last grand rounds in last spring, where we were talking about small testicular masses. You remember we got him through that ordeal in pretty good shape, but unfortunately he's not coped well with the solitary testy, and he's now been dealing with hypogonadism for the last several years. However, the testosterone we've been giving him has kept him looking, pretty good for his age. Unfortunately, comes in now. He had an elevated PSA and an abnormal DRE. He's actually gotten a biopsy showing low volume, low grade prostate cancer. He's pretty angry. He said he's done some reading. He thinks that testosterone's given him prostate cancer. So we gave him prostate cancer. So what should we say about this? And so far, we've talked about this saturation model idea, but how should we really answer this patient's question? What does the evidence say for hypogonadal men who are actually placed on testosterone replacement therapy, TRT? Does it actually increase the risk of prostate cancer? And there's actually been several studies looking at this question, and they've all shown no increased risk for men who are placed on testosterone replacement therapy of developing prostate cancer. One of the largest was based out of the UK. They retrospectively reviewed about 13,000 patients on TRT and really found no increased risk of prostate cancer. And that's what this forest plot's showing, just some of the different analyses they did that essentially all showed no increased risk of prostate cancer for men who are placed on TRT. Another study, slightly smaller in number, slightly longer follow-up, found a similar sort of rate of developing prostate cancer, somewhere between 1 to 2% of men who were followed who are on TRT ultimately developed prostate cancer. So how do the rates of prostate cancer in those studies equate to sort of the general population risk? And it's certainly not fair to directly compare the retrospective studies that I was just showing on TRT to some of these big prospective screening trials like PLCO or ERSPC. as they're not the same. The age will certainly skew a little younger in those TRT studies, not immensely, but slightly younger, and this is certainly going to drop the detection rate of prostate cancer. However, I just wanted to provide some context that the rate of prostate cancer in these patients receiving TRT was not overly concerning. If you look at some of these big screening trials, we see a rate, somewhere just under sort of 10%. So at least we can say that we aren't seeing significantly greater rates of prostate cancer in men on TRT than we have in these large, properly done prospective screening trials. So we explained this to our hypogonadal patient. He seems, begrudgingly pacified, but takes a parting shot at us. On his way out of the clinic, he sees that urologist and appropriately decides to go on active surveillance. But he's back in a clinic a few weeks later, concerned about what he should do about the testosterone he's on. So now we have a guy on active surveillance with diagnosed prostate cancer who wants to remain on his TRT therapy. So what should we do? Well, our choices are actually pretty simple. We can just stop his TRT. He has active prostate cancer or the diagnosis of prostate cancer, or we can continue it. And there have actually been some small studies to try to help us inform our patient on the risks of continuing on testosterone therapy in this exact setting. Unfortunately, there's not been too many large cohort studies that have been completed. Within our own center, Dr. Goldenberg, Dr. Flanagan, Dr. Palmerville in 2016 published a paper reviewing our center's experience of men with a history of prostate cancer treated with TRT. This review found 8 patients who had been on TRT and on active surveillance, and at a median follow-up of about 27 months, they didn't find any pathological progression on any of those men's surveillance biopsies. So it didn't seem in this small group to have increased these men's risks of progression of their disease. A study out of Boston and Baylor of 13 men, 12 with Gleason 6 and 1 with actually Gleason 3+4, who all underwent at least a single follow-up biopsy and only followed for a relatively short period of time. But during the study on their surveillance biopsies, no progression was noted for these men who are all on TRT therapy. Although a total number of patients remains low in these cohort studies, one of the longer follow-up studies was also out of Boston, where 28 hypogonadal men on active surveillance were followed for about 43 months. Of this group, about 3 ultimately underwent treatment for their cancers. 2 of these men underwent treatment because of Gleason score upgrading on biopsy and were confirmed on their final surgical pathology to have Gleason 3+4. 1 man had actually elected to proceed to prostatectomy due to increased number of positive cores on repeat biopsy, but his final pathology actually revealed low volume Gleason 6 disease. So again, it doesn't look like we're seeing this rapid progression. And what's probably the biggest study was a retrospective analysis based on the SEER Medicare data that identified about 1,200 men who were on TRT, and then they used men who were not on TRT but were still undergoing active surveillance, which is about 150,000 as the control group. The study had pretty reasonable follow-up at about 5 years, and they really found no changes in cancer-related mortality between the groups, and in fact found that in the non-TRT group there's potentially even a slightly higher cancer-related mortality that was statistically significant, but unclear if it was specifically clinically significant. So what if we look at this from another angle and look at men with a low testosterone value on active surveillance? So these are hypogonadal men, and see how they fared compared to non-hypogonadal men. And as I discussed earlier, there is some evidence that having a lower testosterone has been associated with an increased risk of developing prostate cancer. And so we see the same trend when we actually look at a man who was diagnosed with prostate cancer? Do we see if they have increased rates of disease progression? So one of the largest studies attempting to address this question, so about 150 men in this active surveillance cohort, did find that on multivariate analysis, men with a lower free testosterone, which is this graph on the left here, did actually have an increased probability of disease reclassification and upgrading. Total testosterone levels just barely failed to meet a cutoff of statistical significance, but certainly that trend was there. And it was felt, if they had a slightly higher number of patients enrolled in this cohort, then potentially they would have been able to achieve that significance. So it did look as though that same trend exists. If you're hypogonadal, your outcomes may be worse for prostate cancer. With an increasing use of MRI in active surveillance cohorts, we can get some insight into the radiologic appearance of the prostate in men on active surveillance, both before and after TRT therapy. In a small but quite nicely designed study, 12 patients underwent a baseline multiparametric MRI prior to initiating TRT as part of their active surveillance protocol. At a median interval of about 48 months, they then got another MRI. Of the 12 men included in this study, 10 showed no progression in terms of PI-RAD scoring on these MRIs, and this was consistent with the surveillance biopsies that these men were undergoing as well. 2 of the 10 men showed no progression in PI-RAD scoring, and this was consistent with their follow-up biopsies. And a small cohort, did actually have this upgrading in Gleason score, unfortunately, but that's not necessarily outside the range of what would be expected in this group, although obviously this is a very small group, so it's difficult to draw conclusions from this. But what is interesting is it appears as though MRI findings are not affected, by testosterone supplementation. And this, continues to add to the group of evidence that addition of testosterone to men on active surveillance, does not appear to be increasing the rate of progression of disease. And although today we're focusing on when testosterone is safe in patients with prostate cancer, something we really should not be losing sight of is why are we even keeping these men on testosterone replacement? And we're doing that because it improves the quality of life for these patients. One study did try to specifically answer this question by screening a cohort of about 200 men for their testosterone levels and assessing their reported quality of life via a few different quality of life surveys. These authors found that the group of men identified as being hypogonadal were reporting significantly lower quality of life outcomes as compared to men with normal testosterone values. And this is really what we're attempting to address by appropriately and safely keeping these men on testosterone therapy and keeping their testosterone values normal while they go through their prostate cancer journey, if this is safe. Furthermore, maintaining a normal testosterone value in addition to just quality of life benefits is shown to be beneficial for a multitude of medical indicators, things like blood sugar control or bone mineral density. So there's lots of reasons why, if we can safely do this, we should be keeping men on testosterone therapy. So with the data that's out there, what are other clinicians at different centers across Canada doing? And there's actually a study surveying Canadian urologists who have experience using TRT or prescribing TRT therapy that showed that a majority would offer TRT to men on active surveillance. Interestingly, only 40% actually had patients who were on TRT and were undergoing an active surveillance program within their practice. And the survey didn't actually ask why there was this discrepancy. So it's unclear if this was, the clinician's inability or didn't want to recommend this treatment. They had maybe low numbers of actual eligible patients who could be included in this group, or potentially, patient preferences or fears. So what do we tell our patient based on this data? So this guy with low volume Gleason 6 disease, who we know is hypogonadal. So we could say, although the data is lacking somewhat, there's certainly no level 1 evidence, and most of the cohort numbers are small. We can say that based on currently available research, we don't see a large signal that testosterone therapy is going to increase his risk of prostate cancer progression. We can also indicate that there's some emerging evidence that does exist that being hypogonadal may in fact increase his risk of progression. One hypothesis of why this may be the case is that perhaps we actually need enough testosterone to generate a PSA response, as per that saturation model, to actually allow appropriate detection of PSA that would occur with prostate cancer advancement. So so we can make the plan with them that as long as he's getting some symptomatic benefit from this, we can continue. Of note, most or almost all of the studies really didn't deviate from their reported, typical active surveillance protocols for men on TRT. And so we could basically continue based on our own center's protocols for these patient populations who are on TRT and on active surveillance. We don't have to deviate too much for them. So our patient continues uneventfully in active surveillance for several years. And as you can see, he's visibly aged now. And unfortunately, a follow-up biopsy does show a few cores of Gleason 3+4 disease, and he elects to proceed with radical prostatectomy. This goes uneventfully. He now returns back to our clinic, and he has an undetectable PSA. So what should we do now? So now this gentleman has a history of prostate cancer and definitive treatment with an undetectable PSA. we have those same two options. We can basically stop TRT or we could continue it. And the main question we really have to answer is, what's the safety of TRT in the setting of a man with a history of prostate cancer, but an undetectable PSA? And so to help us assess the risks of giving testosterone to men following definitive therapy for prostate cancer, we can look at some large database studies. A recent analysis of the Vinci database looked at about 70,000 men undergoing either prostatectomy or radiation. They found about 500 patients in each of those groups who subsequently had been receiving TRT after definitive therapy. Over a median follow-up of about 7 years, they found really no difference in comparison of these groups to men not receiving TRT in terms of biochemical recurrence, cancer-specific, or even overall mortality. The study is particularly strong. It's obviously quite large and it was multi-ethnicity with a nationwide cohort, so it's hopefully reflecting as diverse a group of patients as is possible to really do in a study such as this. There have been several smaller studies looking at the same scenario, showing that following radical prostatectomy or radiation, biochemical recurrence rates do not appear to differ in men who are on TRT from their counterparts who are not. And as I'll discuss, potentially even improve. And so that's certainly encouraging. Somewhat recently, a meta-analysis sort of based on all these small studies showed really no association between TRT and biochemical recurrence in prostate cancer survivors. No effect size was seen between these two conditions. So as we've seen earlier, it did appear as though men who were hypogonadal had increased risk of developing prostate cancer, maybe even a potential increased risk of progressing while on active surveillance. So again, do we see this same trend in men treated for prostate cancer in regards to biochemical recurrence? So in a pretty recent study of 850 men who underwent prostatectomy, 150 were actually found to be on TRT afterwards. And so they followed these men. With a median follow-up that's pretty good of 3.5 years, biochemical recurrence was actually noted to be 12% in the non-testosterone treated group versus only 7% in men treated with testosterone. But what's quite important about this study, though, and what's not known, is what the testosterone values were in that control group. So we don't really know what the prevalence of hypogonadism is in that group who had this 12% rate of biochemical recurrence, as they were not screened for hypogonadism. So this isn't going to actually tell us that guys who are on TRT have a lower risk as compared to non-TRT, but at least it tells us that they don't have, at least in this group, an increased risk as compared to the counterpart who were not receiving this therapy. And so what do our guidelines say in respect to providing testosterone supplementation to this patient population? So both the AUA and the EAU state that it's okay to start TRT therapy about 1 year post-radical prostatectomy. This is presumably to allow for documentation of no residual disease. This is a little bit counterintuitive based on the data that we just presented, and likely represents expert opinion rather than an evidence-based recommendations, because we just don't have a lot of data to do proper evidence-based recommendations in this scenario. The Canadian Guidelines CUA does not provide a specific time point to restart TRT, but does state it can be considered in someone with no evidence of active disease. So all the big guidelines out there do say that it is okay at this point, should a man have no evidence of active disease, to actually prescribe TRT therapy should they be hypogonadal. So let's go back to our patient. So he does well for a few years without any issues, but unfortunately his PSA begins to rise. He's placed on ADT, and with initiation of his ADT, his testosterone is stopped. So now he comes back to our clinic wondering about if he's ultimately placed on an intermittent ADT program, can he go back on testosterone replacement therapy when he's off of his ADT? This is a very difficult clinical scenario. So while on ADT, there's really little concern about what to do, given we're attempting to achieve castrate levels of testosterone. So it's appropriate that while he's on that, that his testosterone be stopped. However, if a patient elects an intermittent ADT, they're looking at this population in the literature of a man on intermittent therapy with TRT during a period where he is off ADT. And there's some discussion of a concept of bipolar TRT, which we will get to shortly. One thing that may occur is that we may actually increase our diagnosis of hypogonadal men in this population, as some men may actually become hypogonadal as a result of treatment with different androgen deprivation therapies. So a study out of MSK of 300 men looking at patients who had received ADT either for greater than 6 months or less than 6 months found that those who had received it for greater than 6 months had a 4 times greater risk of becoming or remaining castrated at 2 years compared to men who were only treated for less than 6 months. So what's important about this is that now we're actually going to be increasing the rate of detection of hypogonadal men, or at least men potentially permanently. So now our patient returns several years later. He's been on intermittent ADT, and unfortunately now that's failed, and he's presented back with metastatic disease. That's now castration resistant. He feels horrible. He asks us if we can put him back on testosterone, claiming he's done some reading, he knows the risks. And so what should we actually tell this patient in this scenario? So a guy who has metastatic prostate cancer, who's demanding that we put him back on TRT. So there's extremely limited data to try to answer this question. There's been a very limited review, about 7 patients who had a mean duration of testosterone therapy of about 5 months. And of these men, 2 patients ultimately did discontinue their therapy when their PSA rose above 20, went back onto active therapy, androgen deprivation. 2 patients died from causes unrelated to their prostate cancer. And this was a very short follow-up, but 3 continued with TRT at the time of publication. We really can't take anything away from the study in terms of outcomes. What's interesting, however, is these were 7 men with advanced prostate cancer who were given testosterone. And interestingly, in the couple of months of follow-up that they had, they really didn't report any incidences of disease flare, increasing pain, or scary things like vertebral compromise. So we didn't seem to see this rapid progression of prostate cancer in these men. That's not to say that we should necessarily be prescribing men TRT in this scenario, but they didn't see what might be expected in this scenario of sort of a rapid progression of prostate cancer. And what about what we'll see in the future in terms of testosterone use in prostate cancer? And there's some evidence that it potentially could even be used from a therapeutic avenue. A controversial topic that's started to begin to accrue some clinical data is this concept of bipolar androgen therapy, short form is BAT, whereby patients are cycled between states of castration and supratherapeutic testosterone supplementation. And this is based on some in vitro observations that although prostate cancer cells with androgen sensitive receptors do well in media with castrate levels of androgens, they can actually be inhibited in vitro once exposed to high levels of testosterone. And one of the first groups to try to clinically answer this question reported on a cohort of 14 men with castration-resistant prostate cancer who were cycled with testosterone injections every 4 weeks, quite a high dose, 400 milligrams, as well as etoposide for the first 2 weeks of every 4-week cycle. 50% of that cohort experienced PSA decline and had radiologic improvement. Obviously the addition of etoposide is going to make it difficult to tease apart if it was the testosterone or the etoposide that improved these endpoints. Interestingly, though, what you can take away from this is that those men treated with further ADT afterwards, so these guys who were castrate resistant, who were treated with further ADT after they had finished the cycle, actually showed further improvements in terms of their PSA once they were re-challenged with ADT, indicating that they may have been resensitized. And this is sort of an important concept that's emerging from this type of therapy.
Luke, can I just interject there? I think what the key part to that is quite different from resensitizing the AR. What you're doing is increasing DNA stress, DNA repair damage with supraphysiologic T. And that's why you co-target with a DNA damaging agent like etoposide or a PARP inhibitor, right? So you're creating a synthetic lethal, taking advantage of what the AR does, which is create DNA stress. And that's one of the reasons why it's oncogenic as well, right, over time. So that's the molecular basis for that combination.
Awesome, thank you. I knew we'd get some good insights on androgen receptor dynamics with the group and experience that we have here. And so look at that same group that actually presented those initial 14 patients has actually done a phase 2 trial with men with metastatic or even biochemically recurrent hormone sensitive disease. This isn't the castrate population. So in this trial, after an initial round of 6 months of ADT, they were cycled with continuous ADT and then high dose testosterone. And so what this does is this creates sort of cycles of high testosterone followed by almost immediate castrate levels following cessation of exogenous testosterone. And so all patients reported a PSA reduction and an 80% demonstrated radiographic regression at 18 months when the study was completed. Given the study conditions, we'd probably expect to see some improvement given that these patients are hormone sensitive and were given ADT. However, importantly, they continued to see improvements even with this BAT cycling, so they didn't see a decrease in efficacy. And again, importantly, one of the points, not necessarily for BAT trials where they are trying to just kill cancer, but these men actually reported improved quality of life when they compared their quality of life scores being on this BAT cycling versus that initial 6 months where they were just on ADT. So when these men were receiving some testosterone treatment, they did seem to actually feel better than when just on ADT alone, which makes sense. Of note, this is not an ideal means for TRT for a man. Going on these high dose TRT regimes where you get this quite a high dose and then nothing else is going to lead to pretty wild fluctuations in testosterone levels. And these men did report that they had improved quality of life in this scenario, but I'm a little curious how these patients would feel on this regime where they're basically cycled up to a super therapeutic level of testosterone, and then days to a week later are hitting a castrate level right again, and then repeating that a couple of weeks later. So they feel very, very good, and then sort of right back down to that sort of castrate level, and that might cause obviously some pretty wild swings for these guys. So the final study I'll talk about today concerns men with metastatic castration-resistant prostate cancer who were enrolled in a phase 2 open label trial. And these men had all previously progressed on enzalutamide. And these patients were given testosterone injections every 20 days, very similar to what I just described previously on this continuous regime. So they're cycling between high testosterone values and then, almost immediately going castrate once that testosterone dose has worn off. If they were to progress on this regime, they were actually re-challenged with enzalutamide. So they'd already progressed on enzalutamide, then they were re-challenged with this if they progressed following this BAT cycling. Of the 30 patients enrolled, 9 did see an initial about 50% reduction in PSA during this protocol. 21 of the 30 did ultimately progress and were re-challenged with enzalutamide. And despite having progressed on this prior, 15 did see a 50% reduction upon reintroduction of this medication. So this medication, which had previously stopped working for them, they did get some benefit from that, at least from a PSA perspective. This question, and Dr. Glia was just providing obviously some further insight into this, is about what the authors were sort of describing as potentially resensitizing these patients to this therapy. And maybe that's more of a catch-all term for allowing some therapies to become still more effective in their ability to basically kill or prevent cancer cell progression. Unfortunately, this group didn't have a proper control group. They weren't trying to. So it's difficult to know how directly tied these results are to this BAT protocol. But certainly it's encouraging. And that's sort of it for my case for when we should be providing testosterone for patients. And I'm happy to discuss any sort of questions or comments around this somewhat contentious topic.